Hi, morning. I'm Taryn and Stephanie. Hi.
Thank you
Steph.
for joining us.
Okay, so just a quick welcome, everybody, to our little session this morning. Acknowledgement to our Indigenous leaders and the traditional custodians of the lands we are meeting here today. And there you go. And to the guys up in Kununurra in the East Kimberley, bit of acknowledgement to the crew up there as well, because they're pretty awesome and we love the East Kimberley. Yay! And apart from that, I'm going to handball straight on. And thank you very much for coming along and supporting our morning minds. I hope you enjoy, and also to the guys from the University of Queensland for coming all this way to help. Come on in. Feel free to grab some food as well if you want to have something. Just a quick note, I will be racing off straight after this presentation. As most of you know, I'll run off and teach my seniors circuit class because we like to keep everybody healthy. But if there's any food, grab something on the way out if you haven't eaten already. And there's some mints there's some hats, there's some keep cups if you haven't already got one, or you just need extras because you've had extras so long.
I'd like to swap them out.
You do. They are very good. I'm going to put some more out there. Feel free to grab one of those on the way out because they are very, very versatile and act as a stubby holder as well afterwards. So you need to keep your Diet Coke cold after, in the afternoon. They work well for that as well. There you go.
Thank you.
Fantastic. And good morning, everyone. And my name's Anthony, and I've got Monica here who's co-presenting with me. It's so nice to see a full room. So it's a real privilege to be here in Bream from Brisbane. So apart from the fact that they both start with B, they're very different places. One is you're quite warm up here, but Brisbane does get warm as well. So it's a real privilege to be here. We're here on behalf of the CRCNA. Does anyone know about the CRCNA? Ever heard of it before in Northern Australia, the Cooperative Centre, supporting research in Northern Australia? So it's a collaborative. We're part of that collaborative, and we've been funded to do a number of different projects in the area of telehealth and virtual care. So my name's Anthony, as I mentioned, and with Monica presenting, my job at the University of Queensland is a professor in telehealth. A long time ago, I was a nurse in paediatrics and child health, so I spent about 10 years and absolutely loved the clinical work there. But then I moved into a small project that was meant to last for 4 to 6 months, and I've been doing it for 25 and a half years. So telehealth has been around for a very long time, not just when COVID hit. But what we're going to do today is kind of do a very quick snapshot of telehealth and virtual care. We've only got 1 hour, and normally we do workshops that can last for 2 days. So Monica and I have decided, well, what can we put in 1 hour that we think will be useful? I've drawn the short straw, and I'm going to give you a little bit of background to telehealth and give you a quick snapshot on what's going on around the country. And then I think probably more importantly, Monica is going to give you a little bit more practical advice about tips on how to do telehealth, how do you kind of make the experience better. And then the slides do not want to move. Yeah, and so I just want to also do an acknowledgement to country and acknowledge the traditional owners, our Aboriginal and Torres Strait Islanders as the traditional custodians on the lands upon which we meet today. And also pay my respects to elders past, present and emerging. And of course acknowledge any Aboriginals and Torres Strait Islanders who are with us today, either in this room with a lovely audience or people connected online. So the centre that I'm in charge of is called the Centre for Online Health. Again, it's about 25 and a half years old. I started with 2 other people. We basically had a couple of wrapped up plastic chairs and a table, and we were meant to work on this area called telehealth and telemedicine. And it certainly has evolved into a very large process now where I have a team of about 15. And our team are quite diverse in terms of their backgrounds. So the backgrounds are more clinical, education, technical, engineering, public health. There's a whole range of different backgrounds that people bring. I like that because everyone brings something to the table. So I think the diversity is really, really important. We're just not a group of academics that think, okay, we're just going to focus on writing papers and grants, even though I spend about 23 hours a day doing that. But it feels like we can actually work closely with clinicians and better understand some of the challenges in doing telehealth.
The arrows working.
Yeah, the arrows aren't working. So Monica and I and Lisa, who's in the back of the room here, three of the team, but then you'll see that there's a lot of other people that are responsible for the work that we do. Why do we love doing the work we do? Well, it's about supporting people who live in rural and remote areas, but many of you will appreciate that telehealth and virtual care is not just about distance anymore. It's about helping people who live away from the health services. And we look after people at the PA hospital in Brisbane who live 1 kilometre away from the hospital. You might think, well, why on earth would you want to do telehealth? Well, one of the reasons is that people may physically have difficulty getting to those services. They may not be able to afford it. They may not have other family support, or they may have other conditions which limit their capacity to go and have those appointments. So what drives us to do the kind of work that we do? Well, there's a whole lot of healthcare challenges, and I'm sure you know all of them. So if you think of things like the ageing population, that's an obvious excuse for saying, well, there's a lot of pressure in how we provide care. The location of specialist services around the country makes us think and have to think more creatively about how we provide services. COVID was a very interesting stimulus in the sense that it forced us to think of, I guess, more innovative ways of providing care. And in some sense, we had no choice because we had to reduce the risk of infection. So we can't bring people into the room. So therefore, we do things by video conference or by telephone. And that certainly helps as well. So all of these factors kind of drive the need to do telehealth. And telehealth in itself, I've heard so many different definitions, what is telehealth? And then we see lots of different terminologies around, U-health and M-health and E-health and digital health, and the list goes on. But it's pretty much just providing a service from one point to another using some form of communication technology. And there's lots of different ways that we can provide care. And I think the first 12 or 15 minutes of this morning, just hearing some conversations happening in the room about where you've come from and also the type of work that you've done. Doing telephone and video conferencing seems fairly commonly used here. But there's also things like e-consultations and M-health as well, where remote monitoring devices can be used to support people. So I just want to highlight a few little examples of how telehealth is happening and being done. And this is really just going through some examples of the work that we've done in Queensland. And it's really interesting to kind of think about telehealth and think about it from the clinical environment. Working in a neonatal intensive care unit, which I've done before, is very different to working in a public health centre. So there's going to be different clinical requirements. So it's really important when you're thinking about your telehealth that you tailor it to the right requirements. It's going to need different technology, a different approach, a different way of working, a different way of communicating. And there's also going to be things we need to think about in terms of what we can and cannot do. So just on the screen there, a couple of examples, and these are older slides, you can tell because of the type of equipment we're using. So check out the big TVs, which took 2 people to carry. Those TVs are amazing, and people used to think, well, this is really, really good. But on the right-hand side in the middle, there's a picture of one of our kids who was being looked after the children with cancer. And this is just an example of how we can use telehealth. So it wasn't a clinical consultation. This was us bringing a busload of kids into the nearby country hospital up in Mackay and me linking up her to her school friends, talking about the formal, talking about dresses, talking about the gossip around school, talking about boys. That's when I had to leave the room, couldn't hear anything. But really, really important that those kind of things can still happen in a hospital environment. So it's not just purely medical or nursing or allied health consultations. We need to think about how we can provide the best possible care to people and think about how we can tailor that with the circumstances that we're in. The bottom right-hand corner, the very dark one, is just a cardiology example. And people would say, well, you can't possibly look at these little babies that are just being born in areas which are 4 or 5 hours flight away from our city hospital. But you can do that by just plugging in the ultrasound machine. So we did about 200 of those, and I offered it 24 hours a day on a mobile phone. So I'd take the call, much to my family's delight. I'd go to the hospital, organise a paediatric cardiologist, and we'd link up. So out of the 200, normally if there's any hint of cardiac disease or a problem with a newborn baby, the normal response would be bringing those kids down to Brisbane. So out of 200, have a guess how many of those didn't actually come down to Brisbane? Anyone want to throw a number?
195.
195? Yeah. Very, very close. 197. So 3 did come down to Brisbane for very good reason. They were retrieved and had surgery and had a very good outcome. But the other 197, you can tell the look on the face of the parents. You don't need to come down to Brisbane anymore. We'll safely look after you in the country hospital. So reassurance for the family and reassurance for the paediatrician, really, really important. We had a bit of fun by building robots. We use these to do mobile ward rounds, but now Queensland Health and the other national systems use mobile systems to do telemedicine. We also use iPads to support kids in the school, and this is a current program that we have. Quite interesting is that we've got some very small country hospitals where these kids would not get speech therapy support or any other physio or OT support. So our idea was to connect up our students at the University of Queensland who are in 2nd, 3rd and 4th year, and they provide the consultations to kids under supervision. So they do it as part of their assessment. And we've got kids out in the country now getting amazing services because of this program. Another example of a program we've done is in a major hospital, the PA hospital, and that model on the screen there really just highlights the structure of this type of program. It's a centralised program where you can offer a whole range of different services, and this is probably the first time that we actually had a very prominent position in a hospital that was basically cleaned out, and we started from scratch. And it's the first time we actually designed a centralised telehealth facility, and this was done back in 2013. But we had a whole series of rooms where all of our specialists could be trained and go in there to do their consults. And it's really interesting. Some specialists take to it straight away, and some will spend 10 years saying, I'm never going to do this in my life, and then they eventually take to it. So everyone's different, and we have to respect that as well. So in terms of the pandemic response, I just wanted to kind of highlight a couple of things that happened. Well, obviously, telehealth became a public name. Everyone became familiar with it, mainly telephone calls. But I just wanted to highlight that that you can see that. It's not going to work. Sorry about that.
I've got a mouse there. Do you want me to order the mouse to attach or make it easy?
So who's using that?
Yeah, using the mouse.
There is one.
I'm just checking that in the remote site, can you actually see the full screen of the slides?
Yep, we're seeing all the slides. Yep.
Okay, good. And can you see one slide or can you see all the slides together?
Just a single large slide.
Perfect. Okay, that's all right. I'm going to do this differently. In terms of the Medicare work that happened, I just wanted to explain the growth in activity. So prior to COVID, there were around 280,000 consultations done every year, mainly video consultations. As a result of COVID, we're now doing about 45 million. So it's a very, very big change. Now, out of those 45 million, about 85 or 86% are done by telephone. So that's a pretty big change as well. It's interesting from a researcher perspective to understand what's happening in terms of the type of telehealth work being delivered and what's happening post-COVID. So obviously COVID was a reason to do a lot more telehealth work, but we're seeing things start to slow down a little bit. And from a researcher perspective, we want to understand some of those reasons why. In terms of the research updates, I just wanted to show you that in terms of the different disciplines, you can see the patterns here on the line that the activity is not disappearing, but it is a hint that some people are wanting to go back to their own ways of working. So we want to try to embrace the changes that have happened and try to keep as many of those new models as possible. So what we need is not just technology. We need to make sure that people are supported. And a key reason of doing these telehealth consults and these training sessions is to kind of help people understand how best to do telehealth. So the work that Monica's going to go into is going to be more around the practical advice of doing that. The other kind of element here is around the evidence. So the evidence for telehealth is now becoming much stronger. We've done some systematic reviews to actually look at the published evidence. I'm not going to bore you with all the results, but I just want to show you that there is strong evidence now from lots of different disciplines to show that telehealth is clinically effective. That just dismisses the occasional person who says, I'm not going to do it because it's not safe. And there's also a lot of evidence here to show that in all these different clinical areas, that in some cases, telehealth can even be a little bit better than what we're used to doing with our in-person services. I just wanted to touch on two kind of main areas where we're currently working, and one is in the aged care space. And it's really, really important with the recent commission report to think about the role of telehealth to support older people. So telehealth can be really useful. Instead of taking people out of the nursing homes, putting them into cars and vans and everything like that and taking them to hospital, then using telehealth between primary care and those residential aged care facilities is very valuable. And we're finding that it's useful for things like GP reviews. We've got hospital avoidance programs, and also the way of providing specialist services into the facility is also another option. So the other area I just want to focus on is one that I'm personally really kind of passionate about. Probably since about 2006, been working with a whole number of different Queensland Indigenous communities. Started my work in Cherbourg, and it started in a room like this over I think it was a Lamington or a pikelet and a cup of tea. And we're just talking about the community and the health services and understanding what people wanted. Before I even mentioned the telehealth word, I didn't even mention it. And one of the problems in the area is they were kind of talking about the kids that had ear disease, and they said we need to do better to screen our kids and get our ENT services out here. So that parked an idea for us. But when people talk about telehealth, telehealth does a number of things. And when you're connecting into different Indigenous services, and I'm sure you have that here, what we're finding is that people are now better connected. So you've got much more culturally appropriate care. You've got people walking into centres where they're familiar with the environment, they're familiar with the people. And I think the types of consultations that happen in these environments is far better than what we can ever provide in hospitals. One of the reasons behind that is they're not just going in there to receive a point of care 5-minute appointment, but you can tell by the interactions, people are asking about the family, talking about school, talking about work, talking about everything else that's much more holistic. So that whole model is a much safer and a much more productive kind of model. Also, the number of stories that I hear where people have to eventually travel down to hospital, have terrible experiences. If we can avoid some of those with the use of telehealth, then that's a good thing. So we've built robots for areas such as Mount Isa that have worked extremely well. The kids absolutely loved it. This program here was our ear, nose and throat screening model. I thought, well, if we can't go out there every week when they need the service, let's get one of our health workers trained to do this work. And we actually built a mobile clinic out in the facility, and this facility still exists today out in Cherbourg. And we've got a health worker who will drive that around and provide screening services. We've done work in dementia as well, where we've provided some public training to let people know about the opportunities that telehealth provides. So there's something on telehealth outcomes. I just wanted to mention that the evidence is showing very strongly that telehealth does support positive clinical outcomes for our Indigenous communities. So just from a practical perspective, and I'm probably talking to the converted because I'm sure that you do a lot of this work already, but the important thing that I teach my team and the people that we work with is that just because I've done have an example of telehealth which is working well in one community doesn't mean it's going to work well in every community. So every community is quite unique. And it's really important when you're planning telehealth to think about what those priorities are for each of the communities and to think where am I going to pitch my kind of efforts first. And also think about the time it takes. It doesn't happen just in 1 week. There's nothing more frustrating when you're applying and doing a grant, and then they say, you've got to finish this project within 2 years. And you think, well, actually, I want 2 years to do good engagement before I do the work. But unfortunately, the government is still sticking to their tight timelines. So we're fighting that battle as well. Keep it flexible. We have staff training that we make sure all of our staff go through the training programs, but also focus about what's going to happen as a result of doing this program in community and what are you going to leave behind as a result of that work as well. Just a message in terms of what we offer in terms of our centre every year. Every second year now, we run a conference called Successes and Failures in Telehealth. So if your invitation to visit us over in Brisbane is open, and our next conference there is in November next year from the 5th to the 6th. So before I hand over to Monica, I'm just going to kind of go over a couple of things. One is telehealth. For those who have never done it before, it might be referred to as a disruptive kind of program or process, but it's worthwhile doing and it can change. It takes a little bit of effort. It's definitely transforming the way we provide healthcare. And if it's done well, it's helping us provide a much more efficient healthcare service, which is more patient-centric to people who need it most. So I'm going to stop there and hand over to Monica to talk a little bit more around the practical nature of doing telehealth, which maybe you'll find much more exciting than me. I'll hand over to Monica.
Okay, for everyone online and in the room, you'd be outstanding if you can, just stand up. Maybe do a little to the left, a little to the right, a little overarm stretch because, you know, we're sitting for 20 minutes. And this is also a distraction as I get my water.
I'm having a live grouper up there straight away stretching.
Okay, thank you, Anthony. No, that was really good. So Anthony's established that he has both a clinical and an academic background, and yeah, he undersells himself. Like UQ is one of the leading research centers of telehealth across the globe, and he's actually also the editor-in-chief of one of the largest journals that's on telehealth. So yeah, we're very lucky. I'm just gonna switch the slides that I'm sharing. So,
Yeah, there's a mystery with the mouse connection on there, not pressing the slides.
okay. The internet connection has been very good. I am super impressed. So yeah, my name is Monica. I'm a telehealth consultant and also a senior research assistant at the Center for Online Health. I haven't been there since 1999 when it started. I was still in elementary school, but it has been about 10 years that I've worked there. So yeah, definitely been around for a bit. We're halfway through loading the slides. Thank you for your patience. And this is going to be a little more practical. There's kind of 4 topics I wanted to cover, and I won't spend more than 5 minutes on each. So don't worry, it won't become very overwhelming, hopefully. How is it looking online? Can you see full screen slides of telehealth content? Yep. Great. So we'll start with some video conference setup tips and troubleshooting. Does anyone here feel like they lack control sometimes when technology is going awry? You just kind of yeah, that is a very common feeling. At the Center for Online Health, right, we do this professionally for a living, and in our staff meetings, we still have people that are like, I can't hear the people. So just know that it's very common. The goal of optimizing our video conferencing is to really reduce the listening effort and the cognitive effort that we have, because you might not even realize how much that's weighing on you when you're trying hard to listen. And also the fatigue you get after video call, video call, video call. It also helps reduce medical legal risk when you know you've got a great connection. We also want to improve communication, effectiveness, and really just everyone's enjoyment, so no one leaves feeling like that was awful. First things first, if you don't currently have your camera at eye level, please go home and immediately do that. A lot of people have their laptop sitting like I have it today, but you can see it's really not the best for eye contact. So put some books underneath it, whatever you have to do. And the reason you do that is because if your camera's at eye level, you can actually look down and the person on the other end won't even know. That's called the gaze angle. And the human eye can't perceive a little bit of difference there. So you can look at the center of a screen and actually still get that eye contact. Really important for rapport building too, to have eye contact. And I just also want to mention, sometimes you might look away from the screen because perhaps you have another screen open that has patient notes or a chart or something like that. It's okay to do that, but just make sure you tell the person why, because sometimes we forget and then they think, are they even listening to me? So yeah, I'm listening to you. I just have another screen over here with your details or some photos you sent me. That's where I'm looking if I look away. There's other, setups you might have to think about if you're going to be connecting to a remote clinician sitting beside a patient. You might want an external camera, something a little more powerful. Or maybe you're going to be sitting with a colleague and the two of you are connecting to a patient together. That's when you really have to start thinking about how far away you are from a screen. And we kind of have this rule of thumb, which is whatever the distance you're sitting away from your screen, you should divide that by 2.5, and that should be the size of your screen. So if you're going to be 2 meters away, you want really at least a 32-inch screen to have the best experience, to enjoy that cognitive effort of trying to see people that are really tiny and far away. And make sure you try to have a private space. I know it's not always possible, but even if you're at your desk and you can kind of just put a little sticky note or page that says, don't tap me on the shoulder, I'm in a video call with a patient or something like that. The most common technical problems we see are usually to do with connectivity and bandwidth, compatibility, some security concerns, those video and audio glitches, very common, and then user error can sometimes happen. When we're talking about bandwidth, that's kind of like slower network speeds, unstable connections, that sometimes your calls just drop out or there's that lag. Some somewhat effective solutions that you can think about are checking your internet connection. So bandwidth is kind of like the amount of lanes of highway. So if you have a higher bandwidth, you have more lanes for that traffic or that data that you're sending to go through. So instead of a 1 megabit per second, try 5 megabit. You can call your internet provider and just see what you have. And you can test it using things like pingtest.net. Usually you want download speeds. I've got there. You can look up this information later. 10 megabits per second is ideal. Another thing that really is helpful is restarting your computer, obviously, but also restarting your modem. Has anyone ever done that before? Pretty rarely, right? But if you think about it, a modem is actually a computer that's on 24 hours a day, 7 days a week, 365 days a year, and it has a residual memory. So if you're, carrying Bluetooth headphones in your bag and they connect for a second and then disconnect, it's going to remember that for 19 years if you don't reset it. So it's going to always be like, hey, Monica's headphones, are you there? Are you there? Are you there? It goes on. It's very neat. I would reset things like that if you're finding that you're getting a lot of lag. You can also clear your browser cache. You can disable something that's called a virtual private network. So that maybe teleservice makes you log into these external systems to access information. If you don't need that for the video call, disconnect it. It'll help. The solutions that I would suggest that are very effective is having a wired over a wireless connection. If you can't do that, you can use Wi-Fi extenders or power line adapters, which are devices that can be plugged in and will replicate the Wi-Fi signal. So if you sit really far from your modem or you're in a building with concrete walls and you're like around an L-shaped corner in Nowheresville land of your building, we work in a ground floor and we actually don't have a mobile phone reception. It's quite ironic for being the Center for Online Health. You can get these adapters and it will actually amplify the signal. I have one at home. It is very helpful. Also really, really helpful is to stop competing applications. So if you're a PC user, this is the old Control-Alt-Delete trick where it brings up the processes or the tasks that you're running. You can actually sort it by the network's use and see what is sucking up all of my that why is the video lagging? And really often it's the email client. So if you have Outlook or something like that open and you don't need it to be open, please close it. That will really help. I also do this a lot, especially when I'm in a Teams meeting. And then you can configure VC camera settings as well. So if you have an external webcam, just look for the settings that might be able to change the resolution to be a bit lower. That will send less data, will help with lag. Compatibility wise, your softwares, they're going to need updates. Drivers on your computer need updates. Make sure you're doing that. And try different browsers for your video conferencing platform if it's one of the kind of internet-based platform ones. Whether you're joining on a PC or a Mac or a mobile phone or a laptop, that will all vary. And if you want to be able to help your client on the other end, it's really good for you to play around yourself. Like if you've only ever done a Zoom call on your laptop, try a Zoom call with a friend once on your phone, just so you know, okay, where is the camera on off switch? Where is the speaker switch? Just so if I do need to help someone, I know what it's going to look like from their perspective. People also sometimes have telehealth links go straight to their junk mail. That's kind of a compatibility problem. I just want to flag that people might need to be told, check your junk. And if you're going to be suggesting any apps or remote monitoring devices, make sure that the person you're talking to has a compatible device, because not everyone will be. If you have any security concerns, you're really keen on being really private and having that as something that's priority. A good place to start is looking at whether your platform has an Australian server. So Health Direct, Pexit, I think CoView all route their data through Australian servers. Platforms will also have or not have something called end-to-end encryption. So if they have end-to-end encryption, it means that when a link is created, for example, on my device, it's encrypted and then it's not decrypted until it gets to my recipient. So they're the only one who can actually decrypt it. So that company itself, like Health Direct, for example, they can't spy on what's going on. But Zoom, for example, could, because they have their own client where they create the links for you and then you can share them. So but it's not always really important depending on what's happening, just like that really fine detail if you're a super privacy nerd. And then there's intrusion protection. So you can have a PIN for a video call that only someone knows to be able to log in. But what's great for intrusion protection, if you haven't picked a video conferencing software for your service or you have any say in it, try to suggest one that allows waiting rooms. So that's when, if you're the clinician, you can pull someone into the call. So you'll see sort of like a virtual waiting room with their name. And then you decide, okay, I'm going to talk to this person. So you can't have anyone just jump in on your call at any time. And then privacy-wise, informed consent is really important as well. So hopefully you're following standards of care like you would in person when you're on video as well. Do take that extra moment to verify someone's identity, that who you're talking to is actually who you're expecting to see. It's not common practice to record consultations. We don't really recommend it, but if you do, just keep in mind that that probably would need to be included with someone's EMR or their patient record, because it's part of that. And yeah, if there is any data breaches, which just sometimes happen, you do have to report them. So video glitches, like I mentioned, often happen when there's those bandwidth issues. So that would be my first suggestion, is to go to those bandwidth issues to try to fix the video lag. If that's not working, you can try using an external web camera instead of a built-in one. You might get better quality. Like there's images on the screen here that show how one is a little bit more true to color, a little sharper image. And also, mobile devices that aren't stationary are going to lead to more data being sent, which can cause video to lag even more. So if someone's on their phone, maybe ask them if they can balance it or just hold it still. Or if you're on a like iPad, can you put it on a stand? Because every time it moves, you're having to send new information over the internet. You have to say, okay, my background had one tree, now it has two trees, now it has light shining, now it has no light shining. So if you can minimize that and have the background be a bit blank, that would be, yeah, better. You also want appropriate lighting, so feel free to control a consultation and tell your person on the other end. I even tell my parents this when we're talking, like, can you please put both of you in frame? Or you're sitting right in front of a window, can you close the blinds behind you? That's on Sunday morning every week. Reminding them again, close those blinds, Mom. Okay. And background wise, I already mentioned neutral is good. And I'm sure you know there's virtual background options we can all use now. Have fun with those too. If you're getting audio glitches, main suggestion really is to use headphones for lots of different reasons. It's more private for yourself. You know, you're really engrossed in that conversation. But it also helps with lag, because if you can isolate the audio that you're sending, that again is less information that has to go over the internet. So when I have a headset like the one that has a built-in microphone, that isolates the audio to only about 20 centimeters around my face. So instead of me telling the internet, here's Monica's voice and here's the leaf blower outside my window, it's just saying, here's Monica's voice. Less information needs to send. And honestly, the leaf blower thing is true. This has happened in meetings and I always apologize. And the person says, I can't even hear it. So that is pretty cool. If you have multiple people in a room too, we suggest often getting an external speakerphone, something like this Jabra one that's pictured on the screen, because audio is really important to get right. It actually has a greater impact than video on the quality of a conference. So if the video is a bit lagging or you don't have great contact, if you can really make sure you nail the audio, people can still have a good experience. And acoustics wise, you might find people kind of yell a little bit, or maybe you even find yourself speaking a bit louder. So try to be in spaces that can reduce echo. I know it's hard clinically, as often like linoleum floors and everything is very sanitary and whatnot. But if you can use carpets or rugs or even something like these acoustic panels, we have got them before and they're easy to move around. They're good for making private spaces. They're good for making a blank background. And they're also good because they're made of like carpet or fabric. So they can help with the echo effect and make it a bit more private. This is a picture of one of the telehealth rooms at our center. And yeah, troubleshooting wise, how do you troubleshoot user error? Well, it's something that's going to happen. The most common problems are usually that I can't hear you or I can't see you. So try switching your speakers or your microphone. Something else that I often find with audio is Bluetooth devices can get in the way. So if someone can't hear you, they might have other Bluetooth headphones or a Bluetooth speaker that's stealing the audio. So just ask them, you know, do you have any Bluetooth devices, or can you turn off your Bluetooth? That might be a problem. Or maybe they just need to get headphones. So if you know how to do these most common problems and help yourself, that can also help other people too. You can also do things like a test call. So I know Health Direct and our telehealth platform at the Princess Alexandra Hospital in Brisbane, they have a test call option. So those are great things to suggest. You can also use the chat function, or if the person you're speaking to doesn't understand chat functions, share your screen and even just put up a notes document, like this example here that says, I am going to call you, keep your video on, like it will be a private number, please answer, and we'll talk on the mobile phone instead. So it's good to have that plan. If all things are perfect, let me just do a shout out for virtual health navigators and administrators that have time to talk to patients. This is a game changer. So if you ever have that opportunity or you can fight for it in your own settings, having people with dedicated time to assist patients will make telehealth sustainable for sure. So how about building rapport and communicating? What are some tips we have for that? When you're starting a consultation or chat, therapy session, whatever it is you're doing online, always introduce yourself, establish someone can hear and see you, check their identity, and check who's with them. Because we've heard stories of some of our colleagues, they're halfway through an hour-long therapy thing and someone looks off screen and goes, is that the medicine I'm on, hon? And you're like, there's been someone there the whole time. Like, so just know who's in the room. Say if you have a trainee with you, keep them on screen, or just say like quick flash, so-and-so is going to be sitting here, but we can't get them in frame. Have a contingency plan, which is that, as soon as you connect, thanks for connecting. If we get disconnected at any point, I'm going to call you on this number and make sure you have your phone with you. And establish the expectations. So ask someone, are you in a private space? Are you somewhere where you're comfortable to talk for the next 20 minutes? Because sometimes they're driving in a car and it's really just better that you say, maybe we'll just reschedule because they might not actually be able to focus on what you're saying. People feel like flexibility is great, but sometimes it's a little too great when you can hear road rage in the background. I would like to highlight that as my nerdy research assistant self has proven through many literature reviews, rapport can be the same over video as in person. It does require some adapting though to make sure that happens. So 6 top tips that I would have for building rapport online with someone is to start and end on a personal note. You don't kind of have that informal chat down the hallway, oh gosh, how hot is it today kind of time. So you do need to make time to do something like that. Maybe if they have a dog in the background, you can be like, oh, what's your dog saying? That's what I would always do because I love dogs. Be more expressive. So nonverbal cues can get missed when you're over video sometimes. So you might need to really exaggerate the nod or exaggerate surprise or smile. It seems really silly, but I think it needs to be reminded sometimes. I already mentioned eye contact is important. Keeping your video on whenever possible, like really trying hard to keep that face-to-face connection, not just audio, is great. And because I mentioned, nonverbal cues can get missed, you really do need effective questioning. So someone might kind of be frowning and you need to just clarify, have you understood what I've said? Maybe they're looking at something off screen that's making them distressed. And also just repeating back to them your understanding to make sure that you're both kind of on the same page. And optimizing that audio and video quality is really going to have a large effect as well, as we've already touched on. We also recommend after you've done any video calls, especially at the beginning, the first few, just actually set aside 5 minutes to sit either with a notepad or just with someone else in your office and reflect, okay, what were my successes there? What went well? And how can I actually improve this for next time? Because reflecting on what worked well and what didn't work well. That's why we have the successes and failures at telehealth conference. We love to talk about the F word, as Anthony said. This would be really good for moving forward and improving. So here are a few more practical ideas for adapting over video if you are in a kind of setting where you do need to do a lot of those practical things. If you have therapy materials that are needed, you normally hand someone in person, you can mail them in advance. Or ask what someone might already have access to. So maybe they don't have, trigger point massage balls and foam rollers, but they've got a water bottle or a cricket ball or whatever it might be. You can obviously email resources and screen share. Doing your own demonstrations on camera are very helpful. And you can send video links with examples of treatment or exercises if you're not able to do them in person with someone. Sometimes that can be better because the person can rewatch it over and over. There are virtual measurement tools. So a lot of assessment tools have gone to digital versions. You just need to check for whatever discipline you're in. You can ask patients to send symptom diaries, their remote monitoring data. You can also ask patients to email photographs if you're finding the video quality is not great or it's dropping out. So if you want to check someone's, range of motion progress, maybe you have them take an image every few weeks or whatever it is, and they can send that through to you. You can request someone to have a support person with them, even sometimes maybe that's their GP or just a family member, depending on what's needed to be done. And you can see patients sometimes, like maybe the first appointment will be in person to get them acquainted with technology, and then all the follow-ups could be over video. So you can use in-person appointment time to really, make that better. Really quick example, speech pathology. These are just some of the digital editions that have been published. And some of these assessment tools are even integrated into video platforms like CodeView. So it makes it really easy. If you do any assessments over video and you have to modify things, just make really clear note of that in their record, their patient chart, whatever it might be, so that you have that on record that there was changes made. And always you can refer to in-person care if video is not seeming effective. So yeah, we loved video before it was cool, before COVID, but we also recognize in-person care is really important. Don't need to force it if it's not the right situation. So I'll finish off talking about embedding into practice. How's everyone feeling? Do we need to stand up again, or we got another 5-minute? Feeling is okay online? You guys need to don't need to go pee? You're good? Okay, great. So embedding telehealth into your practice. The Australian Communications and Media Authority has found, more people are connecting to the internet than ever before, using more devices for all their daily activities. And they're actually seeing the greatest increase in people over the age of 55. That's all that red squiggle is circling. So if you can't read it because it's tiny print, don't worry. And these are probably people that you might see a lot of, like if you're working in primary care or communities where there might be quite a few people over the age of 55 accessing healthcare. That's really exciting. Like we find at the Center for Online Health, patients are quite excited. Like, yes, these scripts are making my life so much easier. And sometimes it's actually just like the healthcare providers themselves are a little bit slower to adopt technology. That's not everyone, but old habits die hard, and also sometimes you just don't have the resources. So yeah, I had a colleague who even a few years ago still given a pager. I'm sure there's lots of faxing happening. So keep in mind that it is happening. Patients are accessing the internet, and we can try to get along and make it easier for them. Anthony's already gone through the evidence, so I won't bother with that. If we want to make telehealth business as usual for us, though, there was a really good international report, and we can share slides later if anyone wants to read more of these details. But for sustaining and optimizing telehealth, there's kind of two broad recommendations. You want to have these foundation components and then some optimization strategies. So foundation-wise, do you have the right technology? Do you have workforce training, kind of, like we're doing today? And also thinking about how you're making access equitable. So telehealth can increase a digital divide, so to speak, if it's done in a way that, it's very restrictive of who can actually access it. So look at where's the internet connections. Maybe you need to get loan devices at your clinic. Like if you can have funding to loan someone an iPad, or I know you're probably thinking like, nope, they're going to nick that and sell it online. Yeah, I don't agree, but you just need to be creative about making sure that people aren't losing out on access to care. So keeping other options when needed. And then optimize wise, in this room, we can be as motivated as we want. We can love telehealth. We can think it's going to change lives. But if our managers, our bosses don't care, not going to get very far. So the idea of leadership is really important. Having metrics or data collected is also really good. That not only helps you, vouch for it in future, show organizations like, hey, we need this because of what it's doing. But it's just nice to celebrate wins if you, have reached a milestone of activity data as well. And you want quality improvement. You want to be making sure that what your service is intending to do is actually happening. So we advise collecting data on your telehealth services. Another really good resource was this document, which summarized telehealth business models around the world. I think it was 20 different business models for telehealth were all summarized, and they found that they all cover these kind of service, tech, organizational, and financial processes. So starting with the service, really looking at your healthcare workflow and how will telehealth fit in, from patient scheduling to people involved to record keeping to billing and auditing. It's great to visually draw that out to make it work within your system. Having the technology that's needed, again, we've already kind of talked on that. And then there is the medical, legal, finance, compliance things that need to be considered. So telehealth has to be compliant with standard clinical practice rules, but there are a lot of national bodies that have telehealth guidelines. I'll show some slides on that in a second. This is an example telehealth workflow. So, it starts with, so you schedule the appointment, you screen the patient to see if they're, appropriate for telemedicine. How are you going to confirm their appointment time? How are you going to obtain their consent? Maybe you need to have them acknowledge that they might need to leave telehealth and come in person if it's not seeming effective. Thanks for joining. These are some example position statements and guidelines for telehealth across different disciplines. So for GPs, nursing, OT, dietetics, physio, psych, social work, speech. And this is where you'll really get that information on who, what, when, where, how, like how do I do telehealth? What is it most appropriate? What do I need to consider? So reference those. Yeah.
I pick up the QR.
Definitely, yeah. No need to do that. I would like you to scan all 95 QR codes one by one. No, thank you. Okay, no. And we had some really good tips for change management. So I can't credit myself with these ones. They're all his ideas, but I thought I'd slot it in here. If you're finding, people are resistant in your settings or kind of forgetting or not picking it up, remember to articulate and advertise why you're implementing telehealth. So is it patients are asking for it? It's good continuity of care. You're reaching people who wouldn't get it otherwise. It's more flexible. Try to get yourselves into a community of practice. So in WA Health, they have, telehealth groups, but you can also just start one amongst your local area, people that are using telehealth. Maybe once every 2 months, you have a half hour, lunch and learn or something like that, where you can share what's working well and what's not. It helps, to a problem shared is a problem halved, or whatever the expression is. You want to legitimize telehealth by using those guidelines that I said, and also looking up literature or, having policies for it, considering it in strategic planning. Don't forget admin staff and the extra work that can be required to do telehealth. Try to have tech support handy. Some of the platforms you use for video might have their own, 1-800 or 1-300 numbers. Introduce telehealth slowly at first, and in those simple cases is best, just so people feel more confident to use it. Allow extra time at the beginning for appointments. Again, celebrate milestones. Yes, we've just done our 25th, video call together, or whatever it might be. And again, encourage in person if needed. Almost done here. 2 more slides of personal skills that you want to be really adept in. Even if you have all those foundational components, we also want our staff to know when and why to use telehealth. This is like 9 domains that came from the literature, but I bolded what's important in green. You can ignore the rest. Managing clinical information remotely is important for staff to know. How to communicate and build relationships online is important. Having basic IT skills is important. How to limit people from being missing out. So like that equitable access to care. Knowing when telehealth is and is not appropriate. Those are kind of the main skills you want people to have. So just acknowledge telehealth might take more time. Don't deny that. Try to adapt differently for how you provide telehealth information. At the hospital where Anthony and I work, they provide video examples of telehealth. They provide written examples, and then they also have a phone number you can call. So whether you're an audio, visual learner, whatever it is. Be aware that patients might feel like you're more accessible than you are. So it's great that there's active engagement, but they might feel like because of telehealth, you're always there 24/7. So just be quite clear about expectations. So, we're going to contact you this many times over the next few months. If you need to contact my team, here you can do it. And just really think, what do you need to see, hear, and do your job well? So it's easy to write off telehealth and think, oh, I saw this dermatology study where the in-person and tele concordance rate was only 80%. It's like, yeah, but did you know that between one dermatologist and another, it's also only 80%? So just try to really think, okay, what is the actual literature showing? What do we need to make this work? And is it possible? It won't be possible in all situations. Finally, like looking towards the future, just be aware we're on the precipice of AI, remote monitoring. Now, some remote monitoring even has MBS item numbers, which is very exciting. So doctors who review that data can claim stuff like that. So we would like to promote the idea of continuous learning and always having a patient-centered focus. That's really what's going to get you the best outcomes in the end. Yeah, the rest were just like wrap-up slides. I don't think I need to go through all of that again. Does anyone, have questions in the last 3 minutes? Thank you for joining online. How are you all doing over there? Good.
Does everyone know that there's a 1-800 Monica number? Just remember that one.
And I need a great answer to the question. I'm just a pretty face. Okay, so I'm good.
You compared telehealth report with in-person report.
Yes.
Is it better when you've had in-person once and then telehealth? Has that been?
Yeah. Yeah. Anthony, do you have any specific examples you want to?
I would say that a lot of people will report that if you know or are familiar with that person, it's much better to do that. However, there's a lot of examples of trial been done where you've never met them before. And if you follow some of those principles, you get a very good experience. But I think from a clinical perspective, it helps a lot if you do know the person. And that's why I'm going to follow up telehealth calls on our phone.
And also the research does show that video is actually preferred over phone for a lot of people. And that video can be more effective than phone as well. So if you can promote the use of video over phone, that's always great too.
I just wanted to substantiate my
Belief.
statement that I always say, let's meet once in person if we
Right.
can, and then follow up.
Yeah.
That's one of the key reasons why Medicare have a rule in general practice as well, that you need to kind of see the patient once a year. And that's kind of forcing, when COVID hit, you probably saw a lot of private telehealth services come up, which in a way concerns me a little bit because you don't know who you're going to connect to. And those private services are still running today, but there's no continuity. And I think that's really important, is to know if you need a plan B, where are you going to go? And is your local provider included in that loop? So I think it's really important to make sure local providers included.
Did you online have any questions or something? Because I know you probably have to go soon and you won't have that in-room chat time.
Just was going to ask if it's if the slides will be available.
Yes, I think
Yes,
that can be done.
Yeah.
I'll send it to you.
Yeah.
Can share around.
Yeah, we'll do the exam first and then we'll send you the slides.
Thank you.
I've got two questions. So just with the Medicare, you don't necessarily need to see the patient first as a phase two. It just needs somebody specific. And okay, and then the other question that I have is that is it going to be is there currently or any plans to embed it so that the conversation, is being recorded whilst, some of the technology that's out now where the conversation is recorded, you can then go back and put that within your notes, because there's nothing more distracting than a person's trying to talk to you. You hang on a minute, when you're trying to optimize them 45 minutes like that or
There's some really smart transcription services, like even with Zoom, where you'll get a transcription which is not always accurate, but it saves you a lot of
you need to go back and review it.
Yeah. So there's no rule to say that you've got to do that and put that into your record. However, I think it's obviously essential you put some record in there and explain exactly what you said and what your decision was.
Right. Okay.
Yeah.
And get informed consent.
Yeah, so you need to, that's what you need to do. You need to be able to ask them at the beginning about their, are they happy? Are you aware this is going to be recorded?
Yep.
So that I can go back, because you're not necessarily going to remember everything, and there might be something vital, detailed, whatever they're actually that we know. And I think also from a medico legal perspective that you want to make sure that you've covered everything.
Yep.
I find it distracting even having a business place, but with telehealth,
Mm.
when you were talking about when you look down so that would be great to have. So
What happens in person in that situation if you're seeing a person in the room? Do you find that you're distracted writing notes?
No, a lot of the colleagues that I'm working with, some in midwife, but a lot of the medical colleagues are actually using that technology because they're actually finding, they feel fine that the appointment is far more robust.
Yeah.
They can concentrate, continue with eye to eye, and then go back. And quite often they'll go back to their notes and go, oh yeah, that's what they said.
Yeah.
Because they didn't remember it because they were engaged elsewhere.
It's incredible what AI can do.
Yes.
And Monica alluded to things that are changing rapidly. And I think there's going to be a lot of changes in terms of the capability we've got. So you do a video link or a call, and straight away you've got a transcript that you can revise and summarize, and then it'll be something you can customize based on your own clinical area as well, like templated.
Yeah.
So things are changing rapidly. So I wouldn't be surprised in the next year or two that we are just talking about that.
Fantastic, because that would be great. I think, I think that would be a better quality. For me, I would find it far more satisfying.
Yeah. Well, that's really, really good feedback. And so if we get an opportunity, we can start feeding that into some of the people doing that technical development work. So it's really good to know.
Would you like
Thank
to
you for that.
work with a couple, either couples counselling and mediation,
Yeah.
and then the transcripts are
Yeah.
really a whole different ballgame. So if you meet with more than one person, it gets really challenging.
Doesn't, yeah.
That'll be fun for AI to learn how to.
Yeah.
that.
I know
Because
in the
there's
university
different
setting,
voices.
in the university setting, they are using it to summarize lectures and presentations, which from a student perspective just makes life a lot easier. And it's basically putting it into a very short paragraph or a dot point structure that you can use as study notes later. So gone are the days when you're sitting there listening very carefully, asking questions. I would say, the students now are.
I think this is the stuff where it is already known that AI will actually make us less sharp, because everything becomes highly processed and we don't actually think and process ourselves anymore.
Yeah.
So I would consider that a risk.
Yeah.
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 And it's,
No,
yeah.
that's good feedback. Yeah.
Yeah, it is. Exactly.
Yeah.
And it's already out on
Yeah.
research that people
Yeah.
are less able to process
Yeah.
because everything is clean cut.
Yeah.
Very much. We don't think as carefully anymore. We
But,
don't-
but from our perspective, it's always been something in health that it's not written down in the act. So, yes, I can understand if way you can actually have two people, but for me, I don't actually want to miss it. So I don't necessarily believe that it's not written down. It doesn't happen. I think there's a lot of stuff that we do that doesn't actually get written down, but the stuff that, I guess the crux of what you're trying to communicate with the person, you've got a clear direction.
So as a counsellor, I make less and less notes because I'm relying and trusting more that what has happened that is significant for my client. It's not necessarily 5 and 5 going down. It's when Mr. Foster. So I trust the process and I trust that it will happen. So if it's a clear medical directive, you want it, and if there is an agreement also, I'll write this down because this is important to be note of. But anything else, the process is the process. Yeah. Anyway, that's completely different.
No, that's good. Are there any more questions online?
Yeah.
There's a good conversation happening there.
Thank you. That was
Yeah. No, that's good. Thank you very much for having us.
Fantastic presentation. Yeah.
When we send the slides, we might also send a link for feedback. So it'd be great. Like, this wasn't a formal full workshop like we do, but we love hearing like what was useful and what was really important that you don't need to know.
Yeah.
Or we also have hard copy sharing like prefers to just like get that ticket off.
So what are you actually doing? I mean, didn't come here to do a presentation research to A on the Thursday night. What else?
This is definitely.
We have workshops.
For those online, we're sort of wrapping up. If you're good to go. Thank you so much for coming, and look for emails. As long as you're registered, we'll be able to send you the slides.
Yeah, thank you so much.
Okay.
Thank you. Bye.
Have a great day. Thanks for what you do too.
Full Thursday. Okay.
No, respond.
They say it's recording. It's because it's so special for insurance. I think one of the programs.
Yeah, but then you like,
Yeah, so-
One not getting money from that.
I gotta say.